moderation for this evening. So we know that after the last few weeks of uncertainty for very odd reasons, now at least things seem to be on track, and we hope to get things forward. The topic of discussion this evening would be a molecule Azelnidipine, which is a dihydropyridine calcium channel blocker, which was introduced about 3-4 years ago. But as we know, I mean, sort of did not quite pick up the way we would have wanted it to. It was authorized for mild to moderate hypertension and uncomplicated cases, and we will be revisiting this indication later. Interestingly, this has been used in the prophylaxis, rather prevention and treatment of esophageal squamous cell carcinoma, and also has been used as part of immunotherapy along with drugs like clazakizumab in colon carcinoma. Today we have three excellent lectures and presentations which would be forthcoming from three very erudite speakers, and they will be dwelling on the cardiovascular aspects, renal aspects, and from the diabetic aspects of the drug as to how and when it can be used. And all the three speakers are very well known to all of us, and they're excellent speakers with a huge background of knowledge and experience. And may I have this opportunity to invite Dr. Sanjeev Gulati, who is the head of nephrology and renal transplant at Fortis CDOC. And I was just discussing with sir that we just got to know that Fortis Escorts has the department under him has been able to do 200 plus transplants of related transplants, and the number is far more larger, 1500 plus from his own center at Fortis Vasankunj. And he remains, he is also the chairman of the Nephrological Society of India, Indian Society of Nephrology, and one of the best speakers around, and with huge experience in nephrology. So over to Dr. Sanjeev Gulati sir to dwell on Azelnidipine and the nephrological aspects of the molecule. Thank you.
Thank you, Dr. Sen Gupta, and good evening, friends. I think it's a great privilege for me to be associated with this group since the time it was populated. I have not kept records, but it's a 50 plus CMEs that I've had the opportunity and the honor to do. But this is the one. Coming to the topic for today, so today we are going to try to learn how to dissect out the various therapies that are available in the market, because there is a problem of plenty right now, and you have to tailor your therapy to the patient. So, Azelnidipine, which is a molecule in focus today, and how does it compare with cilindipine and amlodipine, which has been the gold standard, which you have used for years together. First of all, I think familiar, picture to anyone, any student of medicine. Sir Arthur Guyton, we all read his textbook there, and it was he who said that the kidney is involved in the genesis of any type of hypertension. All forms of hypertension are ultimately the consequence of resetting of the pressure-natriuresis relationship in the kidney, which is why you find nephrologists now at the forefront of management of hypertension. Now, hypertension and chronic kidney disease are closely related. Elevated blood pressure can occur as a result of chronic kidney disease and also a potent risk factor for chronic kidney disease progression. CKD is associated with dysregulation of various blood pressure control systems, including the ability to excrete the daily sodium load. So you have sodium retention, high blood pressure. There is increased sympathetic activation. There is increased renin-angiotensin system activity, and there is endothelial dysfunction. So you have to keep, whenever we are treating chronic kidney disease patients, we have to keep this at the back of our mind so that we can optimally choose the antihypertensive agent, because now there are more than 50 antihypertensive agents in the market. Now this is a landmark study by two endocrinologists, Mogensen and Pavey. And they were the first to show that control of blood pressure slows progression of kidney disease. So in the top you have a patient who's got poorly controlled blood pressure. You start antihypertensive agents. This is the decline in the glomerular filtration rate, and you can see prior to control of blood pressure, the GFR is declining at 11.3 mils per minute per year. But the moment the antihypertensive, this is proteinuria. So the proteinuria is there, but the moment you start antihypertensive therapy, the rate of decline in GFR slows down to nearly 110, and the proteinuria also comes down. So this implied that hypertension contributed to progression of chronic kidney disease. And ever since then, good blood pressure control is one of the pillars of CKD management. And mind you, this was done in an era where none of these current blood pressure medications were available, and today we can actually outdo this. But how are we doing today? Well, this is from a recent study which was published in Lancet Regional Health Southeast Asia, published in February 2023. And this is the pooled hypertension control rate in India during 2 decades. This is 2001 to 2020. It was 17.5%. When they looked at the period between 2016 and 2020, there was actually an improvement by gaining 5%, but obviously we have miles to go. So less than 1/4 of blood pressure patients are receiving optimal therapy. So this is chronic kidney disease. There is inappropriate sympathetic tone, there is increased salt sensitivity, there is upregulation of RAS, there is endothelial dysfunction, increased arterial stiffness. All of this contributes to hypertension and chronic kidney disease. There is no going away from non-pharmacological therapy. Reduced dietary fat, weight loss, reduced salt loss, dietary salt intake, and shared decision making. Thereafter, if you have proteinuria, you could use either ACE inhibitors or calcium channel blockers. So these remain the drugs of first choice, followed by calcium channel blockers. But if you do not have proteinuria, you could either use ACE or ARB with thiazide diuretics, and currently we would use at least 2 to begin with, and thereafter therapy can be added. Again, all this decision making is influenced by age, race, comorbidity, which is what we are going to discuss today, and co-prescriptions, which are not uncommon in our day-to-day practice. So hypertension and chronic kidney disease are the development. They are closely related. The heart and the kidney work together, which is why we have 2 talks today, one by a cardiologist and the other by a nephrologist. So there is what we call a cardiorenal syndrome, whereby the heart and the kidney talk to each other, affect each other. There is autonomic dysfunction, as I said, sodium retention. All this affects the kidney as well as the vasculature. There is an increased glomerular filtration rate, disordered mineral metabolism, metabolic acidosis, systemic inflammation, electrolyte disturbances, anemia, which affect the cardiovascular risk. A significant number of chronic kidney disease patients have cardiac disease, and high blood pressure again on its own, it would affect the cardiovascular outcome. Let's focus on the renal what. So this is the glomerular capillary, this is the afferent arteriole, which brings the blood to the glomerular capillary. This is the efferent arteriole, which takes it away. So this is back to your physiology days. And what happens is in chronic kidney disease, there is glomerular hypertension because there is afferent arteriolar dilatation here and efferent arteriolar constriction. So there is more pressure here within the glomerular capillary route, which causes proteinuria and renal dysfunction. Now let's go at the pharmacodynamics here, and these are the channels. They are the N and T channels here, which are located in the afferent arteriole. In the efferent arteriole, we have predominantly T channels, and the calcium channel blockers act on these channels. Different calcium channel blockers act on different channels. As I said, the L channel is primarily here, but it can be upregulated in a hypertensive patient. The T is there on both. This is again, so this is L, this is N, and this is the T channel. Novel findings suggest a critical role for the type T calcium channels in mediating efferent arteriolar tone. And these T-type calcium channel blockers play an important role of development of chronic kidney disease, which is mediated by multifaceted pathways which are hemodynamic, hormonal and inflammatory. Now, what about Azelnidipine? We all know that Azelnidipine has been there for years together, a very potent antihypertensive agent, but it has its own disadvantages as we have learned over the decade. It causes reflex tachycardia and peripheral edema, which can be quite disabling to the patient at times. Therefore, an effective antihypertensive agent that does not cause this adverse effects and provides end organ protection is required for the holistic management of hypertension. Another drawback of amlodipine is we seem to cause an increase in urea also. So Azelnidipine is a new generation calcium channel blocker that has been recently approved by the treatment of hypertension in India over the last few years. And it differs from amlodipine because amlodipine just blocks the N-type calcium channel, while Azelnidipine blocks both the N and the T-type calcium channels. So this is a diagrammatic graphical representation here. Amlodipine only the L channel, cilindipine we have used for years, also now L and N channel, whereas Azelnidipine blocks the L and the T channel. And this is where again a cartoon which shows the different types of blockage. So this is amlodipine, only the L channel, nifedipine again only the L channel, cilindipine the L and N channel, and you have the azelnidipine which blocks the T channel as well as the L channel. So some other properties, it has a long retention time in the vascular wall. It is highly lipid soluble. Therefore, it is retained in the vascular wall even after clearance of the blood. So, you can easily use it even as a single dose. And it continues to have a prolonged hypotensive effect. As I mentioned, it blocks both these channels, and because of the role of T channels in the zona glomerulosa of the adrenal glands, three other advantages. Now this is an experimental model, the salt-sensitive hypertension, azelnidipine versus amlodipine, comparing that. It was found that azelnidipine decreases the glomerular pressure by suppressing the sympathetic nerve activity, as compared to amlodipine. The efferent arteriole did not contract. Efferent is the one that gets the blood to the glomerulus. So once it contracts, it causes intraglomerular hypertension. And here there is lesser contraction here with amlodipine at the efferent arteriole, and there is improvement in the proteinuria and glomerular injury, which is significantly higher as azelnidipine as compared to amlodipine. So this is the ATTEST study which was published by Katayama et al. In Hypertension Research 2008. So this is a molecule which was discovered in Japan. So most of the literature is published from Japan. It's not received FDA approval for whatever reasons maybe. So patients who receive monotherapy with 8 mg of amlodipine, azelnidipine 112 in propay were compared with 2 mg of ACE 111 for 4 weeks. If the target blood pressure was not achieved, the doses were doubled. And if it was still not achieved, both the drugs were co-administered at 8 weeks, and another hypertensive drug was added after week 16. Combination therapy was found to be beneficial here. And again, after the one-target study where we cannot combine ACE or ARBs, this is actually a very safe combination that we use, especially when looking for additive antiproteinuric effects. So these are some in vitro studies. Treatment with azelnidipine suppressed adrenal, aldosterone and mineralocorticoid receptor dependent superoxide production in rat mesangial cells. It also elicited marked amelioration of aldosterone-induced renal injury through inhibitory effect on an NADPH oxidant-dependent oxidative shift. So some antioxidative advantages also. So these are the effects of the L and T we discussed earlier. You could please skip over. This is baseline azelnidipine reduces blood pressure, but also reduces the heart rate. What about diabetic patients? This is a study which was published in Cardiovascular Therapeutics. The effect of azelnidipine and amlodipine on glucose and insulin at 120 minutes after a 75 grams glucose tolerance test. Reductions in both glucose and insulin levels were significantly greater in the azelnidipine group. Another advantage here, Greater reduction in blood pressure with azelnidipine versus amlodipine, 8 to 16, but mind you, the comparative in this study which was published by Yagamishi et al. They compared 8 to 16 with 2.5 to 5, which is actually as far as amlodipine is concerned, it's a subtherapeutic dose. We all believe in using it in 10 or 15. So this study concluded that oral azelnidipine administration may be an effective therapy in the setting of chronic morning hypertension as well as home pulse rate control. That it definitely does, but whether it is as potent, I'm not too sure. I think personally, I feel amlodipine is probably much more potent than azelnidipine. Sympathetic nerve response and physical stress in hypertensive patients. Sympathetic nerve response is elicited by physical stress. It is augmented in hypertensive patients and it causes increased cardiovascular. Dr. Viveka already speaking about it. But when you compare the two molecules, azelnidipine inhibited autonomic activation and suppressed cardiovascular responses to exercise far more effectively than amlodipine. The sympatho-inhibitory effect of azelnidipine may be beneficial for patients with essential hypertension. It is targeting one more pathway. A word about renoprotection. So cardiovascular disease, cerebrovascular disease and diabetic nephropathy is the unholy triad that is there, and both type 2 diabetes and hypertension have augmentation of inflammation and progression of atherosclerosis. There is onset of CVS as well as cardiovascular disease and diabetic nephropathy. Azelnidipine increases the urine flow, it causes increased glomerular filtration rate. It increases sodium excretion post-treatment without alterations in the GFR and renal plasma flow. It reduces arterial and glomerular injury in the kidneys on long term, and it increases renal plasma and blood flow compared with baseline in patients with hypertension and normal renal function, indicating its potential renoprotective effects. So this is a quick summary that amlodipine targets only the L channels which are there in the afferent arteriole. The azelnidipine targets both the L and the T. The T, mind you, is present in the efferent arteriole. Therefore, it is far more effective in reducing intraglomerular capillary pressure, which is actually increased by amlodipine. So, among calcium channel blockers, azelnidipine is known to possess unique effects such as higher anti-inflammatory effect. I showed you the antioxidant effect. It is more effective in delaying the progression of atherosclerosis and or diabetic nephropathy. It reduces both the serum urine levels and the urinary uric acid to creatinine ratio. So certain other advantages of small decline in uric acid levels, which is an initial risk factor for kidney disease. It reduces tubular interstitial injuries and hypoxia. It increases plasma aldosterone concentration without any change in the plasma renin activity. And given that aldosterone has been implicated in the induction of renal injury through multiple pathways. So this is the anti-proteinuric effect, head-to-head comparison with, this is the baseline. Sorry. So this is the baseline, this is amlodipine, this is azelnidipine, far more reduction in the proteinuria, again reduction in the inflammation. So renoprotectivity of azelnidipine relates to its effects on diabetic nephropathy, which is characterized by increased urine albumin excretion, which is a surrogate marker of chronic kidney disease. Azelnidipine maintains blood flow in the peritubular capillaries also. So by blocking the T channels, it suppresses mesangial cell proliferation by inhibiting activator protein A1, AP1. It also modulates gene transcription involved in pro-inflammatory stages, inhibits aldosterone release, all of them causing additional renoprotection. So azelnidipine may exert renoprotective effects in non-diabetic hypertensive CKD patients via unique inhibitory effects on the age-drag axis also, even in non-diabetic kidney disease. Hypoxia and CKD is, it's protective. This is a study which compared azelnidipine with amlodipine in 30 moderately hypertensive patients, 16 mg versus 5 mg, and urinary protein excretion as well as urine levels of 8-hydroxy DG and L-FABP were compared 3 months and 6 months. Both the drugs reduce blood pressure, but Azelnidipine decreased the heart rate significantly after 3 to 6 months, whereas it was increased with Amlodipine. And the urine protein excretion as well as excretion of these metabolites, which are markers of inflammation, were significantly decreased in the Azelnidipine group as compared to the Amlodipine group. So the study concluded that Azelnidipine is immunoprotective in hypertensive patients with mild CKD, and this action is at least in part due to the antioxidative effect. So it reduces systolic and diastolic blood pressure in hypertensive CKD also, besides diabetic kidney disease. So these are the key benefits of Amlodipine. Azelnidipine can lower blood pressure with causing reflex tachycardia. Without causing reflex tachycardia, as is seen with Amlodipine, it can offer additional venoprotection and prevent diabetic kidney disease if used early. It appears to be an effective and well-tolerated agent for holistic hypertensive management, especially used for tackling the hypertensive epidemic in India, where the population has got high comorbidities, and more importantly, does not cause reflex tachycardia and pedal edema, very important reasons for discontinuation of therapy, and it could be the preferred calcium channel blocker in patients with hypertensive and chronic kidney disease. And this brings me to the last slide. Superior doctors who prevent the disease. It is the mediocre doctors who treat the disease before it is evident, and it is the inferior doctors who treat the full-blown disease. And this molecule will help us graduate from the third to the first category. Thank you for your attention.
Very good.
Thank you very much, sir. And also for joining up here on the desk. The next speaker is Dr. Viveka Kumar. He is the Director Cath Labs Pan Max and one of the most astute cardiologists around, and absolutely approachable to each and every one of us. So can I ask Dr. Viveka Kumar to do his presentation with respect to cardiovascular effects and benefits of Azelnidipine?
Well, so good evening, friends. Thank you, Dr. Gupta, for introducing. But I think my job has been made very easy to, Gulati has already mentioned about the properties of this molecule. So if I ask that molecule, which is, he had some doubts about it, whether it is as potent as Amlodipine, but we'll show you data. But I can also share my experience that it's really potent molecule. It's a very good molecule for renal protection, and as well as I was just sharing our experience with Dr. Chauhan also that there are quite a few patients where we shifted the patient who had reflex tachycardia on Amlodipine to Azelnidipine. And when you look into perspective, I would say it's like a combination of Azelnidipine and Amlodipine. So this is something which is really important, that you need a potent antihypertensive. It can decrease the blood pressure, does not cause reflex high heart rate, reflex tachycardia, and also has a good renoprotective effect. So now we have got molecules which are decreasing the renal dysfunction, molecules which are decreasing proteinuria, molecules which is controlling the blood pressure. So cardiovascular benefit plus renovascular. So that is the property of this molecule. If you look at the hypertension and heart disease, it's really one of the strongest risk factors for cardiovascular mortality. Hypertension is considered to be one of the major risk factors for cardiovascular mortality, and could affect almost 26% of the population worldwide. Recently, there was a study from India, also from all the medical colleges. The one day, almost 100,000 patients blood pressure recording was done, and it was found that in India also almost 40% of people beyond the age of 40 they are hypertensive, but very few people would take the antihypertensive medication. And if you look at the reason why we are after hypertension, is that 45% of the deaths are due to heart disease, 51% is the effect of this is that so Azelnidipine is the new third generation calcium channel blocker, and it has got long retention time in vascular wall. So that is again a benefit that you don't have to really need it. And the azelnidipine continues to have a prolonged hypotensive effect. So meaning thereby once a day or twice a day would be good enough dose. It controls the blood pressure by more additional mechanism. So what it does is that not only blocks the T channel, it also can reduce the secretion of aldosterone, provides the additional blood pressure control. So as you would know that when we define resistant hypertension, we need to give compulsory the aldosterone blocking agents like but this is a molecule which will give addition, so you don't have to add on aldosterone blockage agents. So azelnidipine standalone would be good enough in that situation. It has got a multifactorial on azelnidipine. So what we do is that not only it decreases the blood pressure, there is a decrease in heart rate also, the reflex tachycardia is not there, renal protection is there as Dr. Gulati has said. So meaning thereby that you are protecting all the organs. So the effect and the benefit you get by not only decreasing the blood pressure but also what we call neurotrophic effects that is also there with this molecule. So effect of azelnidipine versus amlodipine in salt sensitive hypertension is significantly better with azelnidipine, and the effect of arteriole, the efferent arteriole did not contract. So whereas in amlodipine it contracted, so that is why the proteinuria part is also better affected by azelnidipine. And it is, if you look at the attest study which is already discussed by Dr. Gulati, this again shows that the blood pressure decrease was significant, and then as the time passes by, the blood pressure control is significantly better with azelnidipine. And if you look at the renal protective effect of azelnidipine, I don't think we need to go into details because it's already been discussed by Dr. Gulati. If you look at the target BP for India with the hypertension, there also we need to keep the blood pressure, whatever the age be, we need to keep it below 130 and diastolic below 80 milliliters of mercury, and that is how the target organ damage can be, protected. If you look at the cardioprotective effect, the azelnidipine lowers the blood pressure and lowers the heart rate. So the major problem with the amlodipine which we are facing and nifedipine, which has gone into Kesaripine. Now the nifedipine is coming in long-acting forms and all, but still the reflex tachycardia part was very high with that, which is not there with azelnidipine. In fact, the heart rate is pretty low, and also the cardioprotective effect. So standalone by decreasing the blood pressure, it can protect the heart, also causes greater reduction in systolic blood pressure, diastolic blood pressure versus amlodipine. So just to remind one comment from Dr. Gulati that it may not be as potent as amlodipine, but in our practice it's been really as potent, I would say, at least as amlodipine without the side effects. So the middle edema is not there, the tachycardia is not there. So the patient compliance is much better with this molecule. And sympathetic now overall when we compare with amlodipine, service azelnidipine, and if you have to switch over from amlodipine and azelnidipine, you can easily go, from the next dose itself you can change to azelnidipine. So there is no titration or anything is required because it is equipotent. So if you look at the sympathetic nerve activity, there also the azelnidipine might be a better treatment option because it does not affect as much as the amlodipine. And if you look at the, there are other molecules like azelnidipine and benidipine. So when you compare with that, the broader cardiovascular benefit of azelnidipine compared with the other agents like azelnidipine and benidipine is far more beneficial. So that is why I think this is a molecule which has got a protective effect, the cardioprotective, and the reflex tachycardia is not there. So I think this is something, and the proteinuria is significantly less also, as Gulati has said. We really wonder that why this molecule has taken so long and is still not as widely used as it should have been because of this property. So probably, I would say that the marketing strategy is that what, if you look at the potency wise, a lot of people feel that probably amlodipine is far more potent, but if you look at the oral azelnidipine administration, may be effective therapy in chronic morning hypertension and as well as home pulse rate control as well. So if you look at the magnitude of drop in blood pressure, amlodipine versus azelnidipine. Azelnidipine is a clear winner, whether it is systolic blood pressure or the diastolic blood pressure. So that is the data which is, not the anecdotes. And if you look at the agent trial also, there also the azelnidipine was a much more potent molecule minus the side effects. So that is why this molecule should be the drug of choice as far as the potent antihypertensive agent is concerned. And sympathetic response and physical stress in hypertensive patients, again, azelnidipine is a superior molecule because of its sympathetic inhibitory effect of azelnidipine. I would say that this is a molecule, this is much better. So if I go to the reduction in heart rate is the strongest point of this, and it also reduces the reperfusion arrhythmias, meaning thereby that if somebody has got a acute coronary syndrome, we suddenly restore the blood supply in the arteries, and we are doing thrombolysis or primary primary PCI. There, the cardiac arrhythmia is much more in patients who are taking amlodipine compared to the azelnidipine, simply because it has got a potent anti-sympathetic activity also, so that why it could be a winner. And if you look at the muscle sympathetic nerve activity, whereas when you compare azelnidipine with amlodipine, obviously the azelnidipine has got a much better data in muscle things also compared to the amlodipine. So I think in conclusion, I would say that azelnidipine compared to the amlodipine exerted a favorable effect on sympathetic nerve activity in hypertensive patients, because when you give the plain vasodilatory agents, like if you give them the Nephro isosorbate nitrate, or if you give them calcium channel blocker, or you give them just the vasodilators like even the ACE and the AR, the patients would have some amount of reflex tachycardia. That is why the molecules which work as an anti-sympathetic agent also, and also potently decrease the blood pressure, are the preferred agent. And I would say that azelnidipine would score significantly over the other molecules, and it may be useful to treating hypertensive patients in whom hypertension is complicated by heart failure and ischemic heart disease. So I think I will conclude my talk at this point, because I have promised Dr. Sunil Chauhan to give him my 10 minutes. Very good request. I think that Dr. Sen Gupta and Dr. Sunil Chauhan will answer the questions which are directed because I have to leave for some other urgent.
Very personal reasons.
Dr. Chauhan will ask you to answer all the questions.
The doctor will go with that.
So, thank you very much for an enlightening lecture. Sir has to leave, so I think the question will be handled by the panel.